To this ad hoc committee on COVID-19 of the Western Cape Provincial Parliament on this frightfully freezing Friday. I hope all members and officials are keeping well. Today we have a briefing on health preparedness and responses. We are joined by the Department of Health from the Western Cape, Dr. Kluti and his team. I'd like to welcome similarly the members of the public and the media that are joining us on the YouTube platform. Let's start with some apologies. We have received an apology from Honourable Philander, and Honourable Mackenzie will be standing in for her today. And then we also received an apology from Minister Mbombo, who tendered an apology when we requested the date for this meeting. However, since the HOD is available, I determined that we should proceed with the briefing rather than waiting for another week or two to be briefed on the health indicators. Are there any further apologies that need to be tabled at this point?
Chair, I've received nothing from my side.
Thank you. All right, then let me just quickly go through the rules of engagement for virtual meetings. All members are muted at the start of the meeting to avoid background noises. Any points of order should please be flagged in either the chat function or by raising one's hand. All audio and video should be switched off to improve the quality of the connection, unless, of course, you are speaking or presenting, then please do use your camera and microphone, and please then put those on mute or off or unflight the presentation, as the case may be, once you have concluded your inputs. Today's maintenance of order come from the directives for sittings of the House and meetings of committees by electronic means, which were ATC'd on Friday, the 17th of April 2020. So on to the meat of today, we're having a briefing by the Department of Health on the progression of the COVID-19 pandemic in our province, with specific reference to the different indicators that we have requested, the modelling on what might be in store for us over coming weeks, then as well as the situational analysis of health responses to the third wave of COVID-19. And then secondly, we've also asked for an update of the vaccine rollout in the province. So it's a great pleasure to welcome the department and Dr. Kluti to our committee again. Thank you very much, Dr. Kluti, to you and your team for your weekly reports, as well as the presentation in preparation for this meeting, which we received yesterday. There are some very hopeful indicators therein that the third wave is plateauing. And at the same time, we're very cautious to make sure that we keep good behaviours to flatten that curve out and to save as many lives and livelihoods. So on that note, I'm going to hand over to you if you'd lead us through the presentation. Please be welcome. Thank you very much, Dr. Kluti.
Thank you very much, Chairperson. I'm going to go straight into the presentation, and I will try and stick to the shortest possible time to make the input to allow for questions and engagement. So my presentation, as forwarded to you, will focus on the surveillance and response update, also the expectations for the third wave, the triggered third wave response that we're currently in, and then the vaccine implementation with some concluding remarks. So just on the surveillance update, a broad overview. This is a daily updated document we've kept all the way from May last year. And it gives us a temporal indication of where we find ourselves. And you can see a first, second, and then a third wave. The gray bars are the cases. The yellow line is the proportion positive. You can see, I'll come back to proportion positive of lab tests. The red line is the reported deaths. And then the blue line is the hospitalizations, people in hospital, and the green line is oxygen use. So these are the markers that we track. And you can see they all very much established into a third wave. And as you indicated, there are some indications that some of them are flattening. The reproduction number is a very important one for us. You can also then look back possibly to the first week in January to see what that means. So when your reproduction number comes down and it goes below 1, that is when you start having decrease in cases and you come off a wave. So you can see the reproduction number has started approximating 1, which is commensurate to the flattening that we're witnessing. And depending on how established this flattening is and whether you've reached a peak and you start going down, we'll only start going down in cases when the reproduction number drops below 1. So this is the national picture, and this is what we benchmark ourselves currently against in terms of expectations. So you can see all the provinces are illustrated here. You can see the red line is Gauteng. There is a very, very sharp decrease in Gauteng over the last 2 weeks. And you can see a lot of provinces, including us, which is the yellow line, are showing signs of plateauing. And you can see where all the other provinces find themselves. Now, this is a national picture. This is our provincial picture then, just to bring it home. That flattening that I'm talking about, you can see in our provincial local data. There's a 3% increase in cases week on week, a week before to last week. That is significantly lower than the increases the week before. So you can see the signs of a plateau is starting to form in terms of cases. The proportion positive, it's the left bottom, is approximating about 40%. And that is the portion of cases go to the laboratory that comes back positive. The one in the middle at the bottom is the number of admissions in hospitals, and then the reported deaths is to the right-hand side, to the bottom. So you can see that currently we see about 2,300 new diagnoses per day, new cases. That's been holding kind of average per day over the last 7 days for the last 2 weeks. That's where the plateauing is coming from. Our admissions is about 330 admissions per day, and we're now reaching about 80 deaths per day. So that's the overall picture for the province. If you go to the metro, it's a 4% increase week on week. You can then see most sub-districts are showing a sign of this plateau that we're seeing in the provincial picture. And there are increasing cases from the public sector. So there was an earlier drop in private sector cases, is now an increase in public sector cases. You go to rural, it's a very similar pattern of plateau. The exception is Central Karoo, but Central Karoo has got very small numbers. If you look to the left, you can see the index talks there about 20 cases, 40 cases. Compare that to Cape Winelands, where we talk about 200 to 300 to 400 cases. So that because the number of Central Karoo is so small, it goes up and down all the time. So it doesn't lend itself to a good epidemic curve because of low population numbers. This is our active cases resurgence monitor. So this is the one. You can see that it's the percentage by which active cases increase. And you can see that's now dropped below 20%. And our active cases week on week has increased only by 4.3%. So we're currently at about 33,000 active cases. I just want to stress this. It is still going up, but it is going up at a slower rate. And that's what plateauing means. It's not declining. It's going up, but slower than what was done before. So we have increased by 1,300 active cases over the last week. The same with hospitalizations. It continues to increase in both public and private sector. And it's about more than 3,000 people are admitted now for COVID. But again, it is slower. It's still increasing, but the increase is slower than expected. This is our excess death as reported by the Medical Research Council. You can see our reported deaths are very much in line with what's reported in the excess deaths. And this is now continuing to increase steeply. It's now exceeding the first wave. And it is commensurate to the increase in deaths. So it's a very, valuable external validation of our pattern that we're seeing. This is our picture a couple of days ago of what the teams report on the ground. It's very important intelligence we get from the ground when people reflect on it. And most of this is household clusters, some clusters in long-term care facilities, old age homes, but mainly household clusters. And a lot of caseload widely distributed across areas. If we look at the comparison between the waves, the light blue line is the first wave, the dark blue line is the second wave, and then the brown line is the third wave. So there, the third wave, again, appears to be plateauing lower than the second wave. And then in the northern, you can see when you look at the geographic area at the bottom left, northern is very similar to the second wave. But Klipfontein, Mitchell's Plain, they're also starting to look similar to the second wave. But in other areas, such as Eastern, Southern, Tygerberg, and Western, it's plateauing out lower than the second wave. And again, in Khayelitsha, the second wave was lower than the first wave. The third wave is lower than the second wave. So that's the pattern repeating itself. This is the wastewater that gets from the MRC, City of Cape Town, Breda Valley, and Theewaterskloof. And the picture on the top is the left-hand picture is last week, the right-hand picture is this week. The legend is the lighter the colors are, the less concentrate of COVID is in the wastewater. So you can see the map this week compared to last week is lighter. It's another validation that if you look at the wastewater and you see particles per milliliter of COVID, in many areas, it's slightly less dense than the week before. If you go to Breda Valley, it's similar. In the Dorens, in Rawsonville, and in Worcester, it's a decrease. But in Touws River, it's kept the same. And Theewaterskloof, Botterivier, and Verliesdorp is the same. And in Caledon and Grabouw, it started from low density, a slight increase in that area. And then just an update on Delta. You can see how the Beta variant was a predominant variant in the second wave. Now in the third wave, the predominant variant in this province, as is for the rest of the country, is the Delta variant. So our expectations for the third wave. And this is the modeling consortium. This is a national modeling consortium that does the projections. So I'll go very slowly through this just because this is one of the key questions asked by the committee. The orange bars represent actual admissions. So you can see when you go orange, it's actual. The blue curves are the model projections for the different speed and strength of the NPI response, and I'll explain that. So the third wave in the Western Cape could peak with similar or fewer admissions than the second wave. And it's very similar to the picture we're seeing at the moment. And expected timing is anywhere from mid-July, which was last week, to early August, which is in 2 weeks' time. Or yeah, it's like the next 2 weeks. So anywhere in the 3-week period from last week till the first week in August, we're in that time where the modeling projection says we should be peaking. Now, you will see on the right-hand side, and I'll explain it quickly to you, the orange shows the actual admissions. What you see as the dark blue line are the different possibilities. Now, the lowest possibility is that we peak slightly lower than where we are now. The next possibility, the next line on top of that, is the one which it's looking like it's approximating now. Then the two higher scenarios doesn't seem to be the ones that we will end up with. So at this point in time, it doesn't seem that we will equal the third wave or be higher than the third wave. It looks like we will come out in terms of what I showed earlier, that our third wave looks that it's going to be higher than the first, but lower than the third. And what this means at the bottom, you will see the darker the line means that restrictions and behavior patterns associated with the lockdown adjusted for has taken effect. Now, if it is not adhered to at all, so everybody disregard the restrictions and nobody adhered to it, then you could have expected that the behavior would have taken the peak higher. But if people were strictly adhering to it, we would have had almost a peaking already and would have been lower than it is now. You can see that the behavioral response is reasonable. It's not as good as it could have been, but it's also not as bad that people didn't respond. And that's why the modeling is currently keeping in line with what we are projecting in terms of our own tracking. And this is more or less what they then do. They give us a short-term predictions on new cases. And up until last week, they were averaging, saying that we will get about the average of 2,500 cases this week, and then 3,000 next week. This week, because of that plateauing, it is now that they're projecting that we will get about 2,500 cases per day this week, which is exactly what we're almost getting. You see the black dots, the gray and the red is the prediction. The black dots is the actual. So this has been actually almost like a very, very sophisticated weather forecast from the modelers. And therefore, they are now predicting on their one that we will have a slightly per day cases next week that's slightly lower than this week. So that is what they're predicting for us currently as the modeling consortium. What does that mean? They're saying that all provinces now in the third wave have a more than 50% probability from their modeling data to have passed the peak. And you can obviously see what that looks like. So for Free State, for Limpopo, it is almost a 95, 96% certainty that they've over the peak. Northwest is a 98% certainty. For us, it's a 73% certainty. So we are slightly behind those ones, Limpopo, Northwest, and even Mpumalanga and Free State. But 73% probability means that it is quite a significant probability that we are starting to peak and starting to flatten out. So what is our triggered response? We've always had this 4-level, what we call a third wave advisory, and it is 4 levels of warning. And we've strictly followed this 4 levels of warning. We are currently in that 3rd level of warning. And that is, if you look at those things, the 20% week-on-week increase in the 7-day average for current admissions. We were 20% the week before. We dropped down to 8% the last week. More than 50% of hospitals have got more than 20% of their beds occupied with COVID. We're currently at 57% of hospitals. More than 50% of high care intensive care, you can see we are at 100% of high care intensive care in terms of critical care access. And more than 100% increase in pre-COVID hospital oxygen use. We are currently using 25 tons per day for oxygen, so that's more than 100% increase for oxygen use. So we've met all of these markers in terms of the 3rd warning, and that is that we continue to be vigilant. We're asking people to behave in a way that the strong public response in terms of behavior is the absolute tool we have at our disposal now to bring the wave, to stabilize it and to bring it down. Mobility data is quite an important one. So you will see the light blue is the Western Cape. On the retail and the recreation, it's always been lower than other provinces. And this is compared to Gauteng, KZN, and Eastern Cape. And there's been an impact in people, fewer people for movement for retail and recreation. For groceries, also fewer. For workplaces, you can see we've had fewer movement toward workplaces. And in the residential movement, there's been a little bit the same as more or less as other places. So what is actually also shown on this is the disruption that was experienced in KZN. You can see in the retail, the complete disruption of movement of people because of the civil unrest in KZN. If we then go to our mitigation, we've always had this 5-point approach, which is changing behavior, changing our surveillance and outbreak, focusing on protecting the high risk, scaling our health platform capacity up, maintaining comprehensive services, and looking after our staff. So what we've done, we've de-escalated non-essential COVID services, both in primary care and hospitals, but we've maintained some essential care, like immunization for children, TB and HIV and those things. Acute hospitals, we've progressively opened more what we call persons under investigation, PUI wards, COVID wards, and COVID critical care capacity, and we've scaled it up to the same level of what we had at the 2nd wave. But that includes also our field hospital capacity. Now, the field hospital capacity specifically, we've stepwise brought the commissioning on. So we started with Brackengate, then we go to Mitchells Plain Hospital of Hope, and we are progressively opening. And when that starts opening, we will add Frisia. And if that starts opening, we will add Western Cape Rehab. And Sonsdale is also open. So you can see that we're doing that in a systematic way. We've not opened all of them. We are watching to see whether the need is there. Then we open capacity and add staffing. Then we also had this coordinated platform response, which basically means patients come into emergency center, but we move them to acute ward, into critical care, into field hospital wards, and we streamline the discharge to make sure there's a flow and that we take the pressure off the emergency centers where ill people present. And then we brought additional staffing in the 2nd wave and flexible deployment across geographic areas and facilities, and then also across vaccination, and COVID management. And then oxygen capacity, it's our daily huddles to make sure that our oxygen capacity does not run into difficulties. So our current picture is more than 3,000 people in acute hospitals. You can see 1,500 in public hospitals, 1,400 in private hospitals. You can also see that in COVID intermediate care number 4, Brackengate at 250, or this morning went up to 280 patients. Frisia and Ward 90 is still 0 patients because Mitchells Plain Hospital of Hope was at 40. We opened additional ward yesterday. They're going up to about 60, 80 patients today, and we'll see how that goes, and then we'll progressively open up other capacity. Soonstraal already has 59 patients, and the mass fatality center had 36 bodies that they're processing, but the bodies are being processed, like in the first and the second wave, quite efficiently. This is our public dashboard. You can see 85% of our public sector hospital beds were full. 24% of these are COVID, and this includes all the hospital beds that I spoke about. To your right, you will see that the pressure that we're experiencing, like the first and the second wave, is on our critical care capacity. So that is 100% full in the public sector, also full in the private sector. But on the non-critical care, which is our general hospital beds, it's about 60% occupied. If we go then to our bed capacity, you can see we had 1,681 in the first wave. We went to 2,300, and we have got capacity to move up to 2,600. So as I said, it's not all open, but as the need goes, we trigger, and we add, and we can go to 2,690. At the moment, you'll see we're at 1,500. So that's where we're going with public sector at the moment. The same with oxygen delivery capacity. Ventilation capacity was 266 plus high flow nasal oxygen in the first wave. That went up to 378 ventilation and high flow nasal oxygen in the second wave. Currently, we're moving towards 420 for ventilation and high flow nasal oxygen, and we're adding high flow nasal oxygen points because the pressure point is in the critical care arena. So the combined utilization currently of oxygen is about 63 tons. That's still within the production capacity in the province. Public sector alone is about 34 tons. And we have put systems in place with AFROX, and our capacity is being monitored on a daily basis. And we are not running into the same kind of difficulty that we had in the second wave. Everything is running, it's quite stable in terms of use, even in the places where there's increased use on a daily basis. Just the trauma picture, we can just see that the impact of alert level 4, with the prohibition of alcohol sales, has had a positive impact on the healthcare platform when most needed in the last 2 or 3 weeks. You can see there was a 25% reduction in trauma patients in 17 of our emergency centers, and also a 33% reduction or 34% reduction over weekends for trauma. Unfortunately, in the last week, there's been a 9% increase of trauma cases and a 70% weekend increase, and that can only be ascribed to the recent taxi violence that we've experienced in this province. This is our healthcare workers, our biggest focus during this time, and it's bringing the additional staff that I've said, training vaccinators, looking after the well-being and the safety of our staff, and then providing resilience of hope. It's stories of hope and engagement to encourage vaccine uptake among the healthcare workers. More than 68% of our healthcare workers are now immunized. And we can see the impact of immunization in fewer infections, fewer hospitalizations, and fewer deaths amongst healthcare workers. But we also have this culture of healing. So the story of hope and collaborative learning, so that we encourage and work with people to support our healthcare workers through this difficult time. So this is the staff capacity. We had 844 in the first wave. We had 1,117 in the second wave. We've retained that capacity through contracts, and we've added 775 on top of that. There's still about another 700 posts that we can do, if need be, in the process of filling. This is the picture that you see in terms of infections amongst healthcare workers. And I just want to draw your attention to where we are now, which is in July 2021. There's a mistake there that says July 2022. That is not quite right. But you can see so far in July 2021, we've had, and today is the 23rd of July, we've had 679 infections amongst healthcare workers. Now, if you compare that to the first peak, and we already said that the first wave was smaller than this third peak. In June last year, we had 1,907 healthcare workers infected in 1 month. If you compare that to 670 in this month, in a higher peak, you can see the impact of vaccination. You can also see, if you compare that to December, we had 2,300 people, healthcare workers infected. And if you compare that 670, which still has another 3 days to go in this month, but you can see it will not come close to those figures. So that for us is the impact of vaccination and the protection for healthcare workers. When I come to the vaccine implementation, this is a timeline for the Western Cape. So you'll see the 17th of February was the Sisonke program. 17th of May is when the national vaccination program rolled out. Then was the rollout of the Educator Vaccine program. Then the EVDS opened for over 50s on the 1st of July. And then we had the correctional services staff uploaded. And then on the 15th of July, we had the EVDS opening for over 35s. Social development sector has been registering. And then the only last outstanding issue will be, which is awaited, when the registration will open for over the age of 18. So what we are putting on this figure is just to give you a sense of what phase 2 is about and what phase 3 is about for the province. So just to quickly go, phase 1, 60 plus, you'll see there's 719,000 people in this province in that age group. 50 to 59, there's 682,000 people in that age group. And if you go to 35 to 49, which opened last week, there's 1,500 people in that age group. So altogether, there's 2,900 people in those 3 age groups. That constitutes phase 2. If you go to the right, you'll see that there's an additional 2 million people between the ages of 18 and 34. That will be the next phase. So what we are going to show you in the rest of the presentation is, in a sense, what we now will call vaccine cascades. So for each of those 4 lines, over 60, 50 to 59, 35 to 49, and eventually 18 to 34, we have created a vaccine cascade. That means total number of people there, how many have registered, how many have had 1 vaccine already, how many is fully vaccinated. So that is how we will be managing our targets from now till the end of December, possibly going into early next year. And just to indicate here, the timeframes have now been adjusted because this rapid expansion has been brought forward with the 35 to 49. Our priorities at our sites now is still over 60s, getting their first dose is still our first priority. Then over 60s getting their second dose, then over 50s getting their first dose, and then people 35 to 49 with a valid SMS requiring their first dose of Pfizer. So we prioritize the most vulnerable, and we systematically introduce the others into the program. This is our vaccine supply line. Today, we're getting a slightly increased allocation. So last week, we got 73,000 doses. That took us to 780,000 doses for the public sector. This week, today, we're expecting 93,000 doses between today and Monday. And we just heard that next week, we will have increased doses on top of that. So over the next 2 weeks, the vaccine supply will start stabilizing and increasing. So therefore, our capacity can then increase over the coming weeks. Our sites so far, we have 216 public sector sites active. On top of that, 118 private sector sites. And the private sector sites, the 118, 85 of that is in the metro, and 33 is in the rural areas. So this is our attainment up until 2 days ago. We sent this presentation to you yesterday. Last night we had an additional 34. Yesterday we did an additional 34,000 vaccinations. So that 90 has gone up to 124,000 for the first 4 days of this week. And you can see that we've now, with this being at 88, 84 the day before, we've now gone over 900,000. In next week, we will hit over 1 million people being vaccinated in this province. 75% done in the public sector, 25% in the private sector. This is our attainment against targets. So you can see the gray is our targets per week for the last 9 weeks. And you can see the brown is the attainment. You can see week 10, which is the one we're about to conclude. We will be very similar to where we are with week 9. And that is in the first week, and where we went, some vaccine supply issues. We now readily and have the capacity to continue to be above 30,000 vaccines a day. And we can, even with increased supply coming for the next 2 weeks, even take that number higher to above 40,000 a week, and that will be the plan for the next 5 to 6 weeks as we go forward. Fully vaccinated is quite important to understand. If you've had the J&J vaccine, you are fully vaccinated. If you've had 2 Pfizer doses, you're fully vaccinated. So currently 272,000 people are fully vaccinated. 131 of those have had 2 Pfizer doses already. These are the special public sector programs. Basic education has been concluded. We did 47,000 out of 54,000, that is 87%. Correctional services has been uploaded and they're coming into all our sites. Revenue services the same. The social development sector is the one we're busy with now. And then defense and military and SAPS is being done separate from us. It's being done by themselves. But you would have noticed this morning, the national minister, acting minister has made the announcement. The remaining special programs will come to an end because now that we've got the age stratified system, everybody will just move into the age stratified system. The CTICC is now operational. Yesterday attained its biggest numbers to date. It did 2,400 people yesterday alone at CTICC. At close of business the day before, already 12,000 was done. But if you add the 2,400 of yesterday, you can see that we went up to almost 15,000 just by the end of last night. We will be at Athlone Stadium mid-August, and it will be similar. It will be multiple stations, and it will be a mass site for the Cape Flats, greater access for people across the Cape Flats. This is our cascade. We now have a daily report on this that we distribute to all our service managers. This is vaccines ordered, vaccines received, and vaccines issued for public and private sector. It also tells you how many people is the absolute population, how many of them are insured, how many are uninsured, what is the population registered to date, what is the actual vaccinations administered, and what proportion of the population has been covered through vaccine. At the bottom, quite importantly, is our sites with our vaccination stations, and that is our capacity to do vaccinations. So this is the cascade, and what it does, the daily report that we send out, it then tells you on a snapshot every day how many people have been registered to date, in which age group. You can see more than 1 million people have been registered. 450,000, the majority of them was over 60. Between 50 and 59, 266,000. Between 35 and 49, 348,000. But if you go to the right-hand side, you can then see what proportion of people in that age group have been vaccinated at least once. Over the over 60s, at least 54% of them have had at least one vaccine. 50 to 59, at least 26%. And then 35 to 49, at least 5.3%. What we then do is we do the cascade, as I explained. So now you can see all the over 60s, 720,000. Then you can see how many has been registered. So we know how many we must register more. And then how many has already been partially vaccinated. And then how many has been fully vaccinated. The idea is to get herd immunity, which is 70% fully vaccinated. So your bottom bar, you want to get to 70% for all the age cascade. So we will only have herd immunity in over 60s if we get to 70% of everybody fully vaccinated. And you break it down into geographic areas. So we can have the same cascade then for Overberg, for Klipfontein, for Garden Route, for Eastern, for Tygerberg, for Mitchells Plain, etc. If you then go into 50 to 59, similar, that's the total age group. That's the ones that's registered to date that you now want to register more. That's the ones at least got their first dose. Then the fully vaccinated, again, you want to get to 70% fully vaccinated. That's herd immunity. Again, we can break it down into geographic areas. And then the 35 to 49 has just been opened. Similarly, 23% already registered. How many has already got one dose? And then how many is fully vaccinated? And again, we want to get to 70%. And when 18 to 34 opens, we'll do the same. We can also then say how many vaccines have been administered in each geographic area across the province. How many is Pfizer? How many is Johnson & Johnson? And we can also say how many vaccines have we received? How many have we issued to the sites? How many has been administered? How many remain centrally? How many is in the sites? So it gives us a forecast capability to be able to plan how we actually plan our vaccinations, that we don't run out of vaccines across the various sites. We also can then give vaccine coverage of how many is given to rural, to metro. Is there equity between the two? And what's the coverage in each of the geographic areas? And then what we've learned out of this first 9 weeks, which is quite important lessons. The important lesson we've learned is that the vaccine story is one of the importance of equity. We cannot leave any person behind. So therefore, this issue of access of metro versus rural towns and districts, we've done pretty well because our access is pretty even across the two. The public sector versus private sector was way much more in the metro in terms of private sector sites, with much fewer private sector sites in rural. And we've been working with our private sector colleagues, and they're starting to increase the private footprint in the rural areas. Then access for insured versus uninsured is our biggest challenge, because the majority of people that has been vaccinated are people that are insured. The majority of the uninsured people have not been vaccinated. It's about going out, reaching them, finding them, and then vaccinating them. And then another equity issue is making sure that the over 60s are covered before other age groups are covered. So it's really making sure that the most vulnerable is covered, then the next most vulnerable, then the next one in terms of that. We also then learned the importance of having differentiated and targeted strategy. In the metro, we have targeted outreaches in the low uptake areas. In the rural is to increase the private sites, but also to have targeted outreach. And then the importance of communication. What to expect, simplifying the process for people, but then also the importance of being vaccinated to counter misinformation and underinformed, people that's uninformed and misinformed, and then also to deal with hesitancy. And we've learned quite a bit of things of how to use community leaders and influential people to overcome the hesitancy. This is the registrations. It's just a little bit more detail of what I've already shown. But we can see we break it down every day now in each area, over 60, 50 to 59, 35 to 49. And again, what I'll do in the red, you can see in the rural areas, Central Karoo remains a challenge. And in the metro, Khayelitsha and Mitchells Plain remains a challenge. And if you go into Khayelitsha and Mitchells Plain, we can now target which geographic area we must go in. But it's not only for over 60s, it's over 60s, 50 to 59, and 35 to 49. It's really getting everybody to get onto the system so that everybody can be vaccinated. In terms of communication, we still reiterate the message of keeping safe. We're not quite out of the third wave yet. It might be plateauing. It's important that we actually flatten it properly and come out of it so that we can go get a decrease in cases in terms of also increasing our vaccination. We now know that 35-year-olds are also being scheduled for appointments. But as I said, there are 4 priorities, and we still very much keep our focus on the over 60s, then the over 50s, and then the 35 to 49-year-olds. But we also have learned the story of being able to go door to door in certain areas, find people. We've also done pop-up vaccination sites, for instance, at SASSA queues in boxer stores. And we've got a great success with these pop-up vaccination sites, so we go to different places so that we can find people. And then out of the boots on the ground and for being available, going door to door, is to have outreach vaccination for people closer to where they live. There is from tomorrow, we will be doing some public sector weekend vaccination. So there are more than 8 sites open tomorrow. There are 3 in the rural areas. There are 5 in metro, but this is being updated today and it's being communicated to everyone. To say where the sites would be. And from next week, it will be more, and the week after, it will be more, as we increase our vaccine doses and our need and our coverage across the different age groups. So these are the messages for the over 35-year-olds. I'm not to repeat that. So in conclusion, Chairperson, we are experiencing a flattening of the wave, but we urge everybody to still strictly stick to the behaviors so that we can really come off the third wave over the coming weeks. We have revised our response. So we've got these triggers for the health platform and society response. We still need a whole of government and a whole of society response to flatten the third wave. We have scaled our vaccination capacity over the last 9 weeks. As we get more vaccines over the next 2 or 3 weeks, we can then scale up and provide more vaccinations. And we need to continue to then actively mobilize, assist, and actively assist people over 35, but especially in people in vulnerable groups and in poor socioeconomic areas so that we can get vaccine equity in this province. Thank you very much.
Thank you very much, Dr. Kuti, for that very comprehensive presentation and for answering the ask of the committee for today's committee meeting. We're now going to move to a round of questions, and we're going to follow the the same process that we usually do, which will be 3 minutes per political party for round 1. And then we'll have answers, and then we'll go to a second round of questions thereafter. So as usual, we're going to start with the DA. Are there any questions from the DA?
Yes, Chairperson, Ricardo Mackenzie.
Thank you, Honourable Mackenzie. Over to you.
Thank you, Chairperson. Thank you for the presentation, Dr. Klute. Dr. Klute, I just want to ask a staffing question. Well done on the information. What is the leave strategy from the minister downwards to you and your staff? Because you guys have been working flat out, and we don't want anyone to burn out. So for your whole staff, what is that going forward? My second question is, given the experiences of the last 18 months, where we were on different level 4, 5, 3, 2, 1, what would you recommend to the president going forward to ensure that we don't have to go into another hard lockdown? Last question quickly. Given the vaccine hesitance in some of our communities, Khayelitsha and Mitchells Plain, have the Department of Health done research to find out exactly what are the reasons people don't want to get vaccinated? Thank you, Chair.
Thank you, Honourable Mackenzie. I'm going to use the remaining time of the 3 minutes. I have 3 questions, please. The first is the graphs which showed the different provinces and the expected peaks or third waves for each of those provinces. I'd be interested to know what accounts for longer or more stretched out waves in some provinces and shorter waves in others. What are those factors that would indicate, for example, that Mpumalanga has a much more stretched out peak compared to Gauteng, and then the Western Cape seems to be sort of more in the middle? Then my next question is, if level 4 is revised next week, is this likely to have an effect on the wave in the Western Cape and how it peaks? Does it mean we might have a longer wave? Is it possible that cases will start to increase? I mean, what are the things that we need to look out for as the levels change, if they do? And then my final question relates to vaccines. You mentioned, Dr. Klute, that the special groups program will be coming to an end. So I would be curious to know whether the Western Cape will still receive a mix of Johnson & Johnson and Pfizer vaccines for the mass rollout program. That's J&J and Pfizer for mass rollout, or will it only be Pfizer going forward now that the special groups program has ended? All right, then that concludes the DA's round. Let me just reset the clock here. We will then move to the ANC. Are there any questions from the ANC, please?
Can you hear me, Chairperson?
Yes, Honourable Windvogel, please proceed.
Thank you, Chair. I welcome the presentation by the HOD. Chair, I also have 3 questions. I really want to understand of what is the justification behind only testing people over the age of 45 years in the province. Then, Chair, to what extent can we expect the recent overcrowding in bus terminuses due to the recent taxi violence to cause an increase in infections in the province? And is it was this overcrowding a super spreader, or do you think that it will be? Then, Chairperson, what I want to understand, which are the predominant variants in the province, and is there a way of breaking down the numbers of infected people according to these variants? Yeah, and I think I will park there. Thanks, Chairperson.
Thank you. Any further questions from the ANC? There are none. Then let's move over to Good. Honourable Heron, any questions from you?
Yes, just 2. Thank you, Chair. The first is about weekend vaccinations. I saw the slide from the National Department of Health with regard to last weekend's registrations, and the Western Cape had quite low numbers of weekend registrations, only 719 according to the graph, and it looks like all 719 were done in the private sector. So why, I mean, compared to the other provinces, and given that there were almost 17,000 vaccines done last weekend on Saturday or Sunday, 719 is a very low number. So I'm just wondering what happened to our planned weekend vaccinations. And then my second question is about about the weekend vaccinations. Dr. Cloete did talk about rolling it out or increasing the sites and the availability. But what is what is holding us back from increasing it substantially immediately? My second question is about the mitigation of the waves. And I raised this in one of our earlier meetings before we hit the third wave as to how we could mitigate the impact of the third wave and reduce it. And I see that in the full presentation that was sent out to us last night, there is a slide which sort of repeats the same things that were repeated after the first and the second wave about communication and changing people's behavior and stuff. But clearly that something is not working if we're not able to change people's behavior and really mitigate these waves. So now we're going out of the third wave and hopefully not into a fourth wave, but possibly and likely there will be. Is the communication strategy working? And is the 6-point slide that talks about mitigation or 5-point slide, is it working? Because the results don't seem to suggest that it is. Thank you.
Thank you. And then finally, we have questions from the ACDP. Honourable Christians, questions from you?
Thank you, Chair. Just two questions. The one is that the vaccination process, some people must travel quite a distance for vaccination. For example, people from Claremont or Kenilworth must go right down to Stellenbosch. There was a lady that was over 70 years old that said to me now she must go to, next week it's the second vaccination process that she must go to, or it was last week, but she must drive from Kenilworth out to Stellenbosch. If Dr. Cloete can just explain why certain people must drive so far for vaccination, that's the one thing. And the second thing that I want to ask is, Dr. Cloete also mentioned the behavioral response, how people behave, and that because people don't adhere to their behavior and they maybe no social distancing, all of that. So does he believe, and I'm just asking this, if does the level 4 restrictions help with behavior or not? And if the president should bring it lower down to level 3, I know the chair, I think, asked something similar. Will it then, will that disturb the pattern of behavior, or is people, with all government departments and people going out and telling people about social distancing and mask and sanitizing, is that enough? If the level goes down, lockdown level to 3, will that affect the behavioral change of people? Thank you, Chair.
Thank you, Honourable Christians. That then concludes the first round of questions, and I'll hand back to you, Dr. Cloete.
Thank you very much, Chairperson. Thank you for those questions to all the members. I will hopefully respond to it very to the point. So, Honourable Mackenzie, your question about staffing, our leave strategy after the first and second wave was very much when we go on the downward slope of the wave, we are encouraging people to take rotational leave. So, for instance, myself, I think you asked me and Minister Mbombo. I've not been on leave for a couple of months, Member Mackenzie. So I will be taking 2 or 3 weeks leave in August. But the point is that we actually have, from the second wave, learned quite a bit, that at any given time, we have actually almost insisted that our managers, clinicians, everybody in our system take a decent 2-week break. And nothing has stopped. We actually have people that can step in, work, and we have to trust that everybody can do the work that's required of them. So let's call it an intentional leave, intentional renewal strategy. we will now come back and look at everybody taking a good proportion of that leave. Then when you said what would I recommend in terms of restrictions, I think the country and the president and everybody that will be looking, and the Ministerial Advisory Committee has met on this, will look at the picture for the country, which is where you have plateauing and coming off the third wave. The intention was always of restrictions is to protect the healthcare platform, the ability of the healthcare system to absorb the pressures. So my understanding is they will take all of that into consideration, and they will probably make some recommendations for certain restrictions to be lifted or to be released. The trick is to find the right balance, that you don't have a rebound of a lot of infections that puts more pressure back on the healthcare system. So I think there are certain things such as curfew times probably will be extended. The issue about movement of people, opening businesses and all of those probably will be extended. I know a big discussion is the issue about returning to school, opening the schools. So I would say that all of those things are quite important things. And I think it's a weighing up of that we've got to the point that we protect the healthcare system, that we can start opening activities, but in such a way that we don't compromise the healthcare system from that perspective. Then from hesitancy, Member Mackenzie, we didn't do our own research. There is multiple bodies doing actually very credible and detailed research. The most important one is the NITS-CRAM study. You might be aware of the NITS-CRAM study. And they've got about an 18-page report that they did vaccine hesitancy study across all 9 provinces, across all age groups, across all different socioeconomic status of people. And there's fascinating details in there, but in short, if I can just summarize it for you in short, the reasons for hesitancy is in certain areas, people are what I would call uninformed about why it's important to vaccinate, and they're uninformed of how to go about it to get vaccinated. And the answers for them is, if I see a community leader or somebody that I trust does it and show me how easy it is, I will follow. So that is what is in most of the poorest neighborhoods, that is the picture. That's also been found. We have met with the people from Limpopo. That's also what Limpopo has done quite well. And they've got all traditional healers, leaders, religious leaders to take that lead and be prominent, and actually prominent community members, leaders have taken the lead in that. The second group, which is the more difficult one, is people that are misinformed. So they're not uninformed, they're misinformed. They've been provided information that makes them hesitant and doubt the effectiveness of the vaccine. Now, the misinformation is more difficult to counter. So there would be people that are misinformed, that are, let's call it, convinced of their conviction, and they will not be vaccinated. We've seen that with children vaccines over the years. So there are people that you're not going to change their mind. But then there are people that are swayed by the misinformation because there's not a counter credible information from a credible source to dispel their worries out of that. So again, the issue there is that the credible information must be shared with somebody that a person identifies with, and it's a community leader. So again, we are targeting our things in terms of our targeted intervention based on the research that came out of that. So it's very useful and practical for us to target our intervention of social mobilization. Member Wengers, the question about the graphs, the longer and stretched out, actually the answer lies, if you just look at the Western Cape's 3 waves, you'll see our first wave was longer and stretched out. Our second wave was a little bit more high. Our third wave looks like the second wave, but it's lower. And if you ask the question, why is Mpumalanga more stretched out and why is Gauteng so high and down? It's basically just a factor of the infections moving in different geographic parts at different rates. Now, if you recall our first wave, when we gave first presentation to this committee, we explained to you that actually it starts in part of the metro, then in another part, then in another part. And at one point, I actually had a slide that showed multiple mountains. So there's multiple peaks that all come together that give you the stretched out picture. That's the easiest way to answer it. So if a place like Mpumalanga, it's a combination of towns, rural, so it moves at different paces in the different areas. As opposed to in Gauteng, it's a big metropolis, it moves quick, fast, everybody's affected, up and down. So that's actually the main reason why you have that. The level 4, the question about likely restricted, I think I've answered that with the first question, is if the right things are taken and relaxed, and we don't take our foot off the pedal in terms of behavior change, which I'll come back to with the other questions from Honorable Heron and Christians, we can still control with lower restrictions, but carefully selected in terms of that. So it does not mean that because you lower the restrictions that you're necessarily going to have a peak in infections. It's about getting the balance right. Then the vaccines, you asked about special groups coming to an end. Basically, the special groups is administratively cumbersome. It's parallel, it detracts from the ability to do a fast, sharp vaccination program. So it's just an administratively cumbersome. By taking the groups away doesn't mean we're not getting Johnson & Johnson. From next week, actually, we're starting to get increased numbers of Pfizer and Johnson & Johnson, and it will be added to the broad program, and therefore we will have Pfizer and Johnson & Johnson in the age-stratified program from the first week in August. So it won't be Johnson & Johnson just for special groups. It's Johnson & Johnson, Pfizer for everyone across the sites. And that is the reason, that was always supposed to be the intention of the original program. But that whole delay with Johnson & Johnson is now to the point where we can actually just move to the original intention is run Pfizer and Johnson & Johnson in the age group vaccination. If I then go to the questions of Honorable Windvogel for the issue about testing, why we are testing only over 45. The issue is twofold. So in every wave, in private and public, in every province, it is very clearly articulated. The primary reason is when you have more infections, the biggest marker that goes up quickly is your proportion positive that comes from the laboratory. So if you have a proportion positive that's under 10%, it means you send 10 samples off, and out of the 10, you get 1 positive. That is good sensitivity. That means you're testing enough, and in all likelihood, you're picking up all the cases. The moment your test positivity goes over 20%, which is 1 in 5, it means already with 20%, you're not testing enough. The likelihood of, because you're only picking up for every 5 cases, you're picking up 2 cases out of every 10 you send. That means that there's probably double the amount of cases out there that you're not testing, because you're not getting to them. So what happens is if your test positivity goes up, the testing as a way of finding cases becomes unreliable because you cannot test enough to find every possible case. For every case that you have when you go to the peak, there's probably 3 or 4 cases that you're not actually picking up. And it became complicated because not all cases have symptoms. So therefore, what we did is we then feel that because you're not going to pick up all cases, we shift our testing to be focused to find people most at risk. That's people with symptoms, it's people that's older, it's people with comorbidities, it's people that's in hospitals, for which we need the results quickly so that we can get them onto oxygen and separate them from others. So that we've done in the first wave, it's done in the second wave, we've done it in the third wave, and it's the rationale is sound scientific rationale for making that specific decision. If you then look at the impact of the overcrowding over the weekend with the taxi violence, the overcrowding with the taxi violence is unfortunate, and it obviously we need to look at the impact of that. I'll come back to it, but we have not seen any big spikes in increase in cases because of the overcrowding. Although it is unfortunate, we've not seen it. There is a possibility that there will be a countrywide spike because of the overcrowding, and that's why gatherings of any nature is potentially a risk. But normally what happens is when we start picking up cases and we start linking it to specific episodes, then we can make that case. We've not seen that specific thing in specific geographic areas where the taxis were overcrowded in that area. The questions about variants being predominant, it's very simple. In December, January, we said all the variants was beta. In the last couple of weeks, Delta took over. So we're not testing again. We're doing 500,000 tests. We're not sending each person's sputum to the laboratory to do genotypes. We're sending small samples. but the sample suggests that the majority of the variance now is Delta. So we don't take every individual person's sputum and do a typing on them to say, you have Delta, you have this one, you have that one. We take a very, very small sample and they do genetic coding. It takes 2 weeks to do the genetic coding. And then out of that sample, we can then say, safely say, almost 100% of all the cases currently is Delta. And there's no difference. We can't tell person X, you have Delta, you have that one, you have that one. That's not the purpose of doing it. It's a surveillance tool to give us a sense of the prevalent. And that's why we're saying almost all the tests we've done on a small sample have come back Delta, and that's the predominant one. That's the surveillance that's being done in that way. To Member Aaron's questions. Member Aaron, the weekend vaccination of last week is a very simple explanation. It was the taxi violence, the impact on staff, not being able to get to places. So we're dealing with that on, Thursday, Friday. All the things we planned for that weekend, last weekend, we cancelled. If you go back to the date of the previous weekend, we did more than 5,000 vaccinations on the previous weekend in this province, 2,700 actually in the public sector and 2,400 in the private sector. We are bringing the vaccination online again this weekend, and we expect that to show up. And our plan is to increase weekend vaccination over the coming weeks incrementally across all the areas. Then the issue about mitigation of the waves and the behavior. The big issue there is the science is very clear. To mitigate the waves, there are 4 big things that plays a role in it. And when we do the modeling consortium, they take all 4 into consideration. So it's 4 very important ones. The first one is, what is the inherent immunity that people have? And that is what's done called by seroprevalence. So if I've been exposed to infections before, and that's the situation that we've had in Khayelitsha, if it's high, so for the next wave, if a lot of people have been infected, then for the next time in a wave, fewer people is likely to get infected. And that's what we call seroprevalence, and that's why we do the seroprevalence study to say which area are more at risk, which have lesser risk, and where we can predict the wave will be higher or lower. But that's only one factor. The second big factor that's now going to complement that one is how many people have been vaccinated. Because vaccinated, like previous infection, will also give you immunity. And the international experience is the biggest way to mitigate the wave is to vaccinate more than 70% of the population. That's where the concept of herd immunity comes from. So our most powerful mitigation internationally is vaccination. That's on top of immunity that you derive from previous infections. Then the third one is probably the one that has played the biggest havoc with us, and it is going to do it, and it's done it nationally, is the emergence of different variants that escapes the immunity that you get from previously infected and escapes immunity possibly of the vaccine that you have. And that's why it's so important to actually track the emergence of new variants. That's the third factor. So obviously keeping on top of it, understanding the variant, testing the variant, seeing whether vaccines work against the variant and whether there's escape, which is the decision that was taken in this country about not using AstraZeneca firstly was based on that one, because there was a study to suggest that the Delta variant and AstraZeneca doesn't work well together. That's why that decision was made in February. That's the third factor that increases or impacts on the size of the wave. The last one is the one that you referred to, and that is the behavior. So it's not one or the other, it's a combination of all 4. And when the modeling look at this, modelers, they're saying the best way to mitigate a wave is that all 4 of these things are ideally monitored and ideally mitigated. So when you ask whether our 5-point strategy deals with this, our 5-point strategy, if you look carefully under strategy number 1, it's behavior. Strategy number 2 is surveillance, and surveillance is to make sure that we track how many people are vaccinated, we track how many people have had seroprevalence, we track how many variants do we have. And then we've added surveillance such as wastewater surveillance, and we've adding other things surveillance such as death surveillance and all the other things. Then in our other things is we look after healthcare workers, we bring capacity online in an incremental way. And that's the way that we've actually mitigated against waves. Now you can ask, what is success in that regard? And there's probably a combination of success, because if you take all of these things together, you probably can have scenarios where you could say our second wave could have been worse. And there could have been scenarios where you say our second wave or third wave could have been worse. But you can also have scenarios where you could say our second wave could have been better mitigated. Our third wave could have been better motivated. That's the learning we have to do, to then say, like you say, a fourth wave should be a blip. And that's why we're going with a cascade, intentionally with the vaccines. Start with the over 60s, go 50-59, then go 35-49. Because if there's a fourth wave in November, December, we want all of those people to be 70% vaccinated. That's our biggest tool at the moment to mitigate against that in terms of that. Then for the ACDP member Christians, the vaccination process, the distance issue is a very simple issue. The system, EVDS, is, I must use the right word. I was almost about to use a word that you might not agree with. The system does not distinguish in terms of who you are, where you live, what your status is, whether you have medical aid or not. The system is designed on artificial intelligence. And all it does, it takes you and say you're due for an appointment. And what it does, when your turn comes up, it seeks the nearest site to where you live. And in that point, now this might be 2 minutes past 4 on a Friday afternoon, it picks member Christian's ID number. Then it looks and says, member Christian lives here. Now, can I find all the sites where member Christians is? Now, it happens to be at that moment, member Christians, that the site closest to you, all the appointments have been taken by other people that's been selected just before, because there's lots of people, 1,000 people are being chosen. Then it says, okay, now I can't find an appointment at the ones here now. Then I go slightly further, I go slightly further. Now that system doesn't make a distinction of whether you take a road this way, that way. It just looks geographically the closest site. That's why it's an occasional occurrence that somebody from Claremont would land up having an appointment given to Stellenbosch. It doesn't happen to everybody that lives in Claremont. The majority of people that live in Claremont, when their number's picked up, will go to the Discovery site in Claremont. But by the time that number's picked, that's full. The next one in Athlone is full. The next one in Mrs. Plain is full. It goes there. It's a very, very rare occurrence. Our system is anybody that has that must give a call. If you give a call to any call center now and you say, this is what happened, the person will tell you, don't worry, I'll give your name to the local team. They will come back to you and they will tell you can go to a site and just walk in with your appointment to the nearest site. The public sector site will help you. So we've got that system in place and we are mitigating that. And most people that got that now, word of mouth, knows that they can just call the call center or just walk in with the SMS at the public sector site. They won't be turned away, especially if they're over 60. Because no over 60 person will be turned away if they got an appointment in Stellenbosch and they go to Lotus River. They will be helped right there on the spot. Then the last one, I think I've answered the behavioral response already, member Christians, in terms of my response to the other members. Thank you very much, Chairperson.
Thank you very much, Dr. Klutti. Apologies, it took me a little while to get off mute there. We still have some time in our meeting here, so we'll go to a second round of questions, if there are any. Would members indicate by a show of hands? Again, we'll start with the DA. I see Honourable America. Please go ahead.
Thank you, Chairperson. Thank you, Dr. Klutti, for the presentation, and we are delighted to hear that you'll be going on leave shortly, soon in fact. I want to preface my question with a remark, and that is a month ago we had the bushfire in Seabrook, the Swellendam area, and it was very concerning to all of us, because of an infection breakout at one of the packaging stores there, Thornlands. But I'm happy to say, Dr. Klutti, that the interventions that your department made certainly dealt sort of expeditiously with that sort of bushfire. So in Seabrook, the active cases as of yesterday was just 5 active cases, and in Barrydale in particular was 9 active cases. So we're very thankful for that. Having said that, Dr. Kluter, the public announcement that a vaccination program would have been conducted today in Barrydale was just cancelled, and our residents received an SMS that they must return for the second dose Pfizer vaccine on the 28th. So the question here, was that cancellation as a result of a lack of vaccines, or is there perhaps any other reason why it happened? The second question is regard to the 4 phases or the 4 categories that you identified, but we don't have a sense yet of how we are going to deal with undocumented immigrants or people who don't have IDs, and then the EVDS system does not permit people to register without a valid South African identification, because certainly within that category of people there are, nobody must be left behind. So perhaps if you could possibly just give an indication to us as to at what stage, whether it has been discussed at national level yet, will we create a category where those people could register. Thank you, Chair.
Thank you, Honourable America. You've used the full 3 minutes, so I'm going to move over to the ANC now. Sorry, Honourable van der Westhuizen, hopefully there'll be another round where you'll be able to pose your question. Honourable Windvogel, please go ahead.
Thank you, Chairperson. Thanks, HOD, for that response. On the taxi issue, I would assume there are a lot of people who cannot leave their homes due to the taxi violence and end up missing their appointments. How are you dealing with that issue? And then on the issue of the 50 years and above, do they have to first, is it still that they need to register first and wait for SMSs or can they just go to the vaccination point to get vaccinated? The reason I personally think it would assist a lot if we increase the vaccination capacity to include walk-ins in our vaccination sites, especially in our townships. So just clarity on that. Thank you, Chairperson.
Any further questions from the ANC? Okay, if there are none, then let's move on to Good.
No, thanks, Chair, I'm covered.
Okay, thank you. ACDP, Honourable Christians.
Chair, I'll give my time to Honourable van der Westhuizen. Thank you.
Thank you. That's very gracious. Thank you, Honourable van der Westhuizen.
Thank you, Chair. Chair, regarding the testing of wastewater and the graphs and the deductions made from that, I am concerned that many of our wastewater systems are prone also to ingress of storm waters, particularly now during the rainy winter months. And I'm concerned that that wastewater is heavily diluted. When you speak to municipal engineers, they have this problem in winter of their wastewater works being flooded, literally. And my question is, can your tests or analysis, can that compensate for the dilution by stormwater? And my second question, Chair, is we do have some people under the age of 35 who need to travel internationally for their work. I can just imagine that some may even have to travel internationally to represent their country in various fields. And some countries now apparently insist that people coming from countries with high infection rates, such as South Africa, be able to show that they've been vaccinated. Is there any talk of opening up, vaccination for under 35s that are, going to travel abroad, need to travel to other countries, etc., or what are the options open to them? Thank you so much, Chair, and thank you to Honourable Christians.
Thank you kindly. All right, that then concludes round 2 of questions. I'll hand back to you, Dr. Klute.
Thank you very much, Chairperson. So I'll start with Honourable America. Just to indicate that, and I'll come back to this theme because it's quite an important one. We would want to be able, when we have made a public announcement, to come to an area like Berrydale, that we are going to vaccinate people there. Our biggest need is, or our biggest desire is not to cancel, because we know it disrupts people. But that specific instance is one example of many, which I will come back to, which is how to manage your available vaccines. Now, remember on the cascade I showed, we have supply that we have for specific number of days. But now if you are in a rural area like Overberg, and specifically you are now in the Swellendam sub-district, and your plan is you want to go to multiple points, all of a sudden you must take your cut of the doses being given, and you now need to plan it so accurately that you can now go to various places and have there. So the situation that we have when we have to do the cancellation is because there's not sufficient doses to do it on the day. That's why we preferably tell people, rather come on the 28th, and we will come to you, and we will have sufficient doses when we come. That's why we are at pains to say, you can never have, as I showed you, 280 points, almost 300 points, and at every point have a completely unlimited supply of vaccine. It's never going to work, and it's never going to happen under any conditions. So that's why logistics planning and planning for supply and demand becomes an important issue. And that's why predictability of vaccinations becomes important. That's why scheduling is important for us. Because if you just have walk-in without scheduling, you can imagine one side will quickly use all the vaccines and nobody else has vaccines. So this issue about being fair, spreading it, I mean, one of our colleagues in the rural areas is literally like spreading fish paste on a piece of toast, because you need to spread and cover every corner. I have so much empathy for our staff in the rural areas, and they're taking abuse from people of the public, which I think is unacceptable, because they're trying to take what they have and try and reach every community in a fair way. And especially the reason why they want to do it is so that you don't have to cancel this area or that area, and be fair in terms of access. Then in terms of undocumented immigrants, that has been very clearly articulated with the National Department. It needs not only an ID number for South Africa, they are recognizing passport numbers from other countries. And there is a mechanism that we now want to get with Home Affairs of how we do registration for people that are undocumented. So there is mechanisms being tested, and we will be as part of our outreach, get to special groups to be able to overcome this specific challenge. So I know the team is working very hard on that, because in every geographic area, there's a team that needs to go out and find undocumented people and homeless people to actually vaccinate them and give them access as well. Then remember, Windvogel, the taxi issue is a sad issue. The impact it has, the biggest impact it had is on people's mobility. Now, at the height of that taxi thing, that was last Thursday, Friday, there's just 120 nurses that can't get to Grootske Hospital. Whereas Grootske Hospital's admissions in the COVID wards are going up. The nurses just can't get there because they are dependent on public transport. The people that have appointments, now you can imagine we have scaled down appointments. So therefore, the impact on people with appointments was a little bit less. The big impact was actually on our staff getting to their workplaces and getting back from the workplaces back home. And that's why we had to cancel the weekend vaccination. There was 1 or 2 places where we even had to cancel just the overnight services because of not just the taxi violence, but also the threat the staff had when they tried to get to work in relation to that. So I think appointments was lesser affected, because there are lesser appointments anyway. I think the biggest impact was actually staff trying to get to places, and then patients or people with appointments trying to get to vaccine sites would have been affected by it. Your second question for your the question about whether people over 50 should register and wait for an SMS, that's the biggest challenge that we have currently. So I put in the presentation for you the following. If I have a medical aid, if I have a car, if I can work on the internet and and I'm mobile, I am more likely to be vaccinated than somebody that does not have a medical aid, that lives in a poor area, that does not have access to data. So what we now need to do, and that's what I call, it's the need to have a differentiated strategy. So we cannot have the same strategy in Claremont than we have in Khayelitsha or in Crossroads. We have to have a different strategy in Khayelitsha and in there. That's why we're talking about the door-to-door. That's why we talk about the pop-up sites. That's why we talk about all of those. So we're going to have to find ways of doing registration plus vaccination in the poorer neighborhoods. And our teams are working very hard with local religious leaders, local community leaders to actually get that action. And the same applies for a farm worker that lives on a farm in a very, very remote area. You cannot have a system in Claremont for the farm worker on the remote area. So that is our biggest challenge, and we will be working. And again, it's getting the balance right, because we need to have sufficient vaccines to go out. But then you can hear the person that shouts the loudest is, now you're taking vaccines to go find people, but I'm here, I demand a vaccine right now, and I don't want to be told I must cancel. It's those balance. And again, the staff sit in the middle and they take the abuse from the demanding public, plus the fact that they've got an obligation to find the person that is uninsured and is deserving of the vaccine to go to them. So that is the balance that we will discuss on Monday in great detail, but we are committed to finding uninsured people and have different models to find coverage in the underrepresented areas. Then, Member van der Westhuizen, I think the point that you make is valid. The scientists that do look at wastewater takes into consideration the storm water that comes in and all of this. But the big thing that they're doing is they are looking for the presence of COVID. It's tests that they do to see whether there's particles from the wastewater runoff. Now, obviously, when there's a storm water, they take that into consideration when they test their samples. So it's also how they take the samples, how it's analyzed, what the interpretation is. So they have a whole range of things that they do to be able to make contextualize the findings of the water and not to make invalid conclusions out of that. And then under 35s that wants to travel and for overseas, there are many people that ask for many reasons. At the moment, as a provincial health department, and we are pretty happy to stick to that. Our responsibilities for over 60s, firstly, because we want to protect people for the next wave. Then it is 50 to 55-year-olds. We also want to protect them against the next wave. Then it's 35 to 49-year-olds, because a lot of them are working, but a lot of them also have comorbidities. So for our purpose, our primary focus with the vaccines we get is to get maximum coverage for those groups. Anybody that has a special request for under 35, and that's where the issues of unfairness comes in. Because the point is, if you give it for one person, then somebody else is a reason, another reason. National Department has put a mechanism up for all special requests, but there's more than 5,000 applications waiting for more than 2 weeks to be considered by them. At this point in time, we keep our lives simple. We stick to the parameters of the program because it's based on reaching the most vulnerable and getting the biggest coverage for what we have. Thank you very much, Chairperson.
Thank you, Dr. Klutty. We do have to get through quite a lot of admin in this meeting, but I'm going to open for a final round for any follow-up questions. I'm not going to do it by party. If individual members would just raise their hands if there are any follow-ups emanating from Dr. Klutty's responses, we can pose those questions now. And if there are none, then we will conclude the engagement with the Health Department. All right, any final questions from any members? Honourable Mackenzie.
Thank you, Chairperson. Just one question for Dr. Klutty. I know the stakeholders meeting, and I'm also part of the stakeholders meeting within the Mitchells Plain cluster every Monday, and then Minister Fernandez have a stakeholder. Is there a similar meeting with businesses, a stakeholder meeting? Because I find at times, in just a practical example, Chairperson, I'll be very quick. Metro Rail just sent out a tweet, trains has been cancelled because of COVID cases. Now, they've been doing consistently for the last 2 weeks. And I'm just trying to understand, and I did send a WhatsApp to Richard Hawker, that obviously you can't shut down a whole train because of 1 or 2 COVID cases. So, but I'm trying to understand, is there a engagement with businesses about how to solve COVID cases at their businesses and get their business back operationally as soon as possible? Thank you.
Thank you. Any other questions from any other members? Going once? Twice? All right, that then concludes the round of questions. Dr. Klutty, for that final question from Honourable Mackenzie, please.
Thank you, Honourable Mackenzie. There are stakeholder meetings, and I can just explain to you what they are. The ones that you are involved with is the geographic stakeholder meetings. It's called the hotspot coordination. So there's an MSc and a head of department doing it for every geographic area in the province. But that is to bring all stakeholders together in one place. Then there's sector-specific stakeholders. So Minister Meyer, Minister Marais, as the faith-based leaders, that's a regular stakeholder forum. I go to quite often, give this presentation. But the Department of Economic Development and Tourism has also got a stakeholder meeting with all businesses. And we also go regularly to that specific forum. I think the bigger issue here is, and I've always made it to my colleagues in the top management, we've also said it at Cabinet. COVID is not the health department's problem, it's the whole of society's problem. And therefore, every individual has to behave responsibly, but then every organization that employs people have to respond responsibly. So it's incumbent on organizations to keep their business going, especially if it's essential businesses, to make sure that they got their processes in place, they do what they need to do, to not interrupt and disrupt the life of ordinary citizens. So it's incumbent on everyone to do that, but there is a stakeholder forum for businesses via the Department of Economic Development and Tourism. Thank you very much, Chairperson.
Thank you very much, Dr. Klutty. Thank you very much to you and your team. Again, for presenting to this ad hoc committee this afternoon. So with that, that concludes your participation in this meeting. So thank you to you all. We wish you a warm and safe weekend. Thank you.
Thank you very much, and thank you to the members. Thank you.
And you must enjoy his leave, Chairperson.
Yes, if we don't see you before then, please have a well-deserved break, Dr. Klutty. All right, members, let's move on to committee admin. All right, are there any resolutions, recommendations or requests for information emanating from today's meeting or Monday's meeting? None, all right. We then don't have any recommendations or requests for information from Monday's meeting. If there are any from today's meeting, you still have until next week, Monday, 12 o'clock to submit any. If there are no resolutions and actions from today's meeting, then let's move on to consideration and adoption of reports. Let me ask the procedural officers, Ms. Hassan, Musa and Ms. Jones, if they would assist us. I think we're starting with the draft report of May, is that correct? Yes. No, we're starting with the draft report of the 11th of June.
Sorry,
right,
Chair.
these all, that's all right, no problem. These all have been circulated. So let's start with the 11th of June. Let's just check. Here we go. The committee membership has not been corrected on that report. Please, can we correct committee membership?
Sure.
Honourable Botha is a permanent member. Okay, then let's just check there. Okay, then that's corrected. Honourable van der Westhuizen.
Chair, with that amendment, I would like to propose that the minutes be adopted.
Okay, the report. Okay, I just wanted to go by page to see if there were any other edits or amendments from the members. So could we go to page 2? Any edits or amendments there? Okay, if none, then let's move on to page 3. I'm just consulting my notes also. Sorry, members, please bear with me. All right, there are no edits or amendments there. Let's move on to page 4. Hang on, page 4. Okay. Right, if there are no edits or amendments, can we, Honourable Bartman?
Chair, just under page 4, I think on the first or second paragraph of page 5, I think approximately just needs an extra E.
Okay, let's edit that. Okay, and then can you please delete 5.1.4? It repeats 5.1.3. Or delete 5.1.3, that's probably easier. Okay. Then page 6, I think it's just a signature page. Let's just check. Yeah, all right. Can we then adopt the report with the amendments? Honourable Bartman?
Move to adopt.
Thank you. May I have a seconder?
Seconder, Chair.
Thank you, Honourable America. Then let's move on to the minutes of the 11th of June. Okay, here it comes. Right, please check attendance. Okay, then moving on to the minutes themselves. Okay, page 3.
Chair, apologies.
Yes, Honourable.
On page 1, I just wanted to check if Procedural Officer Musa's surname was spelled correctly.
Okay, let's correct that. Thank you.
Chair, whilst there, can we just go back to attendance? Sorry.
And what are you missing there?
Yep.
Thank you. Thank you for pointing that out. We just have to correct that. It says JL there. Right. Okay. Perfect. Then moving on. Then the resolutions were the updated weekly report from the Department of Health, which is already in effect. Then a breakdown of the number of persons that have not been vaccinated per district. That is contained in today's presentation. Okay. All right, and then those were the requests as per the meeting. All right, could we adopt these minutes with amendments? Honourable Bartman.
Thank you, Chair. I move to adopt.
Thank you. Could I have a seconder?
I'll second.
Thank you, Honourable Botha. And then we move to the final document for consideration today, which is the draft report of May 2021. Right, this is report number 13 for the ad hoc committee. Let's just check this. The committee membership is correct in this one. Thank you. Page 2, that is then a standard for all the reports. Moving on to page 3.
Chair.
Honourable van der Westhuizen, thank you.
Under paragraph 5.2, it starts then with 5.2.2, which I think should be 521.
Thank you.
And then in the second line there, it says it could result in a third wave.
Which line is that? Please help me.
Under the old 5.2.2, the second line, the first paragraph, the Minister of Health, it could result in a third wave.
Okay, right, that's been corrected now. Thank you very much for spotting that. Thank you. Then we move on to page 4. Page 5. All right, can we adopt the draft committee report of May 2021 with amendments as discussed? Honourable Bartman.
Move to adopt.
Thank you.
Sorry,
May I have a
Chair?
seconder? Honourable van der Westhuizen.
Yeah, Chair, the acknowledgements on page 5 is also numbered 5.
It should be 6.
Yeah, I think it should be 6. Thank you, Chair. And with that amendment, I would support the adoption of the report. Thank you.
Thank you. I'm going to pose the question again then. Can we adopt the report for May 2021 with corrections?
Move to adopt.
Supported.
Thank you, Honourable Bartman and Honourable van der Westhuizen. The report is duly adopted. Right, thank you very much, members, for your participation in this meeting. We finished a bit earlier, being a Friday afternoon. I think that is a bit welcome for most. Please stay safe, stay warm. I'd like to thank the procedural officers for all their work in having convened and prepared for the meetings this week. We extend our sincere gratitude to them both, as well as to the senior Mr. Daza. All right, everybody, stay safe, stay warm, have a good weekend. The meeting is adjourned.
Thank you,
Thank
Chair.
you.
You too.
Bye.
Thank you, Chair.